Hi, my name is Brittany Seal, and this is my genetic and fetal assessment and pregnancy assignment. My chosen topic was EFW and AFI scans through an ultrasound. An estimated fetal weight, or an EFW, is performed by using an ultrasound to gather measurements of the fetal head circumference, biparietal diameter of the head, abdominal circumference, and femur length. To calculate the EFW of the fetus, you must combine these measurements all together. The EFW can be plotted on a graph to help determine if the fetus will be average, larger, or smaller in size for its gestational age. Surveillance of fetal growth is essential for good prenatal care. It can decrease the chances of a stillbirth or other complications. The sensitivity for this test is between 52 and 57%, and specificity was at 88%. A growth assessment protocol algorithm for fetal growth surveillance is used to determine the need to gather an EFW. Women with no risk factors receive low-risk care, which includes a serial assessment of fundal height from 26 to 28 weeks until delivery and an anatomy scan of the infant. Women with risk factors or suspected abnormal growth should get an EFW done anytime after 28 weeks. If the woman has more than one risk, then she is considered high risk. She should get an EFW every 3 weeks from 28 weeks until delivery. Indications for getting an EFW includes having one or more risk factors, which can include advanced maternal age, tobacco use, drug use, hypertensive disorders, diabetes, large fibroids, overweight or obesity, history of an SGA or LGA baby, and a previous stillbirth. There are no contraindications for getting an EFW scan. The combined measurements are plotted on a graph where a percentile is provided. The normal percentile for the fetus should fall between 11 to 89% for its gestational age. If the fetus falls at 10% or below, then it is considered small for its gestational age. If the fetus falls at 90% or greater, then it is considered to be large for its gestational age. Either of these abnormal results should be followed closely from the initial scan and up to delivery every 3 weeks. This knowledge can help the provider to educate the patient on risk for each abnormality. For SGA fetuses, should educate the patient on complications after delivery, such as poor temperature regulation and poor glucose control. For LGA fetuses, educate the woman on the possibility for a shoulder dystocia, cesarean section, poor glucose control, or poor temperature regulation. EFWs for a woman who is at a high risk can help prevent stillbirths. It can help to educate and minimize birth trauma such as a shoulder dystocia by monitoring the growth of the baby and inducing the woman if needed. EFWs can also help prepare the woman for the possibility of needing a cesarean delivery if the infant grows too large for her birth canal. A disadvantage for an EFW could be that the measurement was off and the woman was induced sooner than she needed to be, or a cesarean delivery was performed. The abnormal results can also cause unnecessary anxiety to the woman if they are not accurate. Educate the woman on the accuracy of the exam. Results are not 100% accurate. Based on findings, educate the woman on what to expect during labor course, based on the size of the fetus. For an LGA fetus, educate the patient on shoulder dystocias and the maneuvers that may be performed to get the infant delivered. If the infant becomes too large, it may be recommended to go through with a cesarean delivery instead. For SGA and LGA fetuses, educate the mother on monitoring and risk after delivery such as blood glucose levels and temperatures. An introduction to the AFI. The amniotic fluid index, or AFI, is a standardized way to assess the sufficiency of amniotic fluid quantity in pregnancy. It can diagnose too much or too little fluid, which is known as polyhydramnios and oligohydramnios. You can begin screening AFI levels after 20 weeks of gestation. If levels are abnormal, an individual may be monitored by getting their AFI scanned every 4 weeks until delivery. If the individual has oligo or poly, then it is recommended that they be induced at 37 weeks gestation. The sensitivity of the AFI scan is 38% and the specificity is 83%. AFIs are collected anytime an individual gets a growth scan done, a biophysical profile, decreased fetal movement, a post-stage pregnancy, or a suspected rupture of membranes. Some women may never have an AFI scan performed during their prenatal care. AFI scans are done by ultrasound and are very safe, therefore there are no contraindications. An AFI is calculated on an ultrasound machine. The uterus should be divided into 4 quadrants to assess amniotic fluid. The ultrasound transducer should be held perpendicular to the patient's spine, not perpendicular to the patient's skin as it is in most other ultrasounds. Measuring perpendicular ensures that each pocket is being measured on the same plane. The deepest vertical pocket of fluid in each quadrant should be identified and measured, and these 4 measurements should be added together to calculate the total amniotic fluid index. It is able to screen and diagnose abnormal fluid levels. This allows the healthcare provider to intervene and prevent complications such as fetal death, IUGR, preterm rupture of membranes, a cord prolapse, and uterine atony. Interventions that can be done to prevent these includes an amnio infusion in labor, injection of fluid during an amniocentesis, drainage of fluids, and medication therapy such as Indocin. Indocin helps to reduce fetal urine production and output, which decreases the fluids. Disadvantages would be present if the levels were measured incorrectly or the scan was off and the patient was induced early, or other interventions were implemented. Normal AFI levels is between 5 to 25 cms of fluid. If the fluid is less than 5 cms, then this indicates oligohydramnios. If the fluid is greater than 25 cms, then this indicates polyhydramnios. If an abnormal result is present, the patient will have levels measured every 4 weeks until delivery. If levels remain persistently abnormal, interventions may be indicated to drain fluids or add some back. For oligo and amnio infusion or amniocentesis can be done to add fluids, and for polyhydramnios, Indocin can be given or an amniocentesis to drain fluids can be provided. For teaching, it is important to educate the patient on what these levels mean for her and her infant during this pregnancy. You should inform and educate her why interventions may be needed to add or drain fluids to keep her and the fetus safe. It may indicate the need for an early induction, so this should also be discussed with the patient. And here are my references.